Well, hello everybody, and thank you for joining us tonight. It's 5:01, so I think we will get started this evening. My name is Pam. I work for JDRF, and I have a couple of my colleagues on the call as well, Erica and Danielle. Thanks for joining us.
Good evening, everyone.
So on behalf of JDRF, we'd like to welcome you to our Let's Talk T1D educational series. This week is Mental Illness Awareness Week, and today we have 1 hour to listen to our speaker, Dr. Mona Gupta. Thank you for joining us, Dr. Mona Gupta, and our topic is T1D and your mental health. JDRF has been a global leader in the search for an end to T1D through both research, funding, and advocacy. We also support people and families along the way by helping those live better, healthier, and safer lives while we find a cure. So I'd like to provide just a brief overview of this series. Since COVID, we've not been able to safely meet in person. So JDRF created the Let's Talk T1D series. And the series includes both the education series and the connection series. The education series is a presentation on a new topic every month, and we will be updating our website soon with details for the next session called Tech Talks, and that will be taking place on November 16th and 17th, so stay tuned for those details. We also host a virtual connection series on the 4th Wednesday of each month. This is an unstructured opportunity to connect with others with no formal programming. So if you'd like to learn more about that and sign up for our next connection series on October 28th at 7 p.m. Eastern Time, you can visit our website at jdrf.ca. So before we get rolling here, I just want to go over a few housekeeping and technical items. We are going to be a big group tonight, so to minimize background noise, we have everyone on mute. Your camera is an added feature, and we encourage it for you to turn it on to interact with Dr. Mona Gupta, but it's not required. There's also a raise hand button. So if you need clarification during the presentation, you are welcome to raise your hand, but we also have a chat function, and we really encourage any questions to be commented in the chat, and we will try to get them to them at the end if we have time. So some conversations might be difficult for those new to the world of T1D. Please note that our series are designed to have discussions around T1D and might paint a very real picture of the challenges. And I also just want to make a note that this session will be recorded. In the chat along the side, it's kind of like the little bubble that you'd see in a comic strip. If you click on that, we'll also be providing our JDRF email addresses in there as well if you'd like to email us with any comments or feedback from the session. So now I would like to introduce our speaker, Dr. Mona Gupta. She is a psychiatrist at the CHUM and a regular researcher at the CRCHUM. She is also associate clinical professor in the Department of Psychiatry and Addictology at the University of Montreal. She received her medical degree from McGill University and did her residency and fellowship in psychiatry at the University of Toronto, where she also did her doctorate in bioethics. The broad theme of her research concerns the interaction between ethics and epistemology in psychiatry. In her clinical practice, she works mainly with adult patients with T1D. She has been involved in the research and development of new clinical programs for people with T1D and mental health issues. Thank you so much for being here today with us. Dr. Mona Gupta, I will pass it over to you.
Thanks so much, Pam, for the introduction, and hi, everyone. I'm very happy to be here. I hope you can hear me okay. This is actually quite lovely. I'm at home, and it feels very conversational. So I'm actually not going to be giving a formal presentation. I'm going to be responding to questions that people had sent in to the organizers. And so feel free at any time to jump in if there's something you want to clarify, or if it's your question and you want to add something to the question, that would be just fine with me. I've just prepared this list so you could sort of see the broad themes that we're going to be talking about this evening, and people's questions fell under one of these themes. As I did this on Monday in French here in Quebec, and I actually ended up saving the pandemic issues till the end because there was a big announcement in Quebec that day about further restrictions, and so there might be lots of things people want to say. So maybe we'll do the same thing today so that we can make sure that we cover the diabetes-specific questions as we're going along. So as Pam said, I'm a psychiatrist, and I've been working with people with type 1 diabetes for most of my career. It's not the only thing I do, but it's the majority of what I do. And I've met hundreds of people with type 1 diabetes over the years in the course of clinical practice, and I've learned a lot about them. I've learned a lot about type 1 diabetes from them. I don't have type 1 diabetes myself, so really my experience is from learning from the people that I've been working with. So what I'm going to try to do today is to answer your questions, and I'm really going to draw on what I've learned from the people I've met over the years and the work that we've done together to try to answer those questions. I'm going to try to channel their experiences, and as a result, some of what I'm going to share with you isn't necessarily what endocrinologists or other doctors or diabetes educators would tell you to do, but it's what the people that I've worked with over the years have told me that they've done in order to cope with the challenges that they've experienced in living with the disease. So when I first started out doing this kind of work, I wasn't really sure what my role was, because often I'd receive referrals from endocrinologists who would ask me to essentially help the person become more compliant or adherent with what was being prescribed to them, the routine that was being prescribed to them. But as I worked more and more with people, I started to realize that, in fact, that was not my role, regardless of what it said on the consultation request. But my role was to really help people to survive and thrive despite the challenges of the disease. And these are the things that I'm going to share with you this evening. So many of the questions that people sent in were quite broad, so I'm going to give some general answers to those questions. But if it's your question or the question is interesting to you and there's something specific you want to know about that topic, feel free to jump in. And I believe Pam is going to moderate all the questions, so anyone can really chime in at any time. So maybe can we move that slide and just go to the gallery? Yeah, that's great. So hello, everybody. Now I can see some faces. It's nice to see you. So the first broad group of questions fell under the heading of the link between type 1 diabetes and mental health. And the question specifically that was posed was, do people living with type 1 diabetes experience more depression or anxiety as a result of the disease, not necessarily related to living with type 1 diabetes, but in general? So I assume the qualifier means, is there some kind of a causal relationship between the disease itself and different mental health problems? So what I can tell you is that there's been a lot of research in this area over the last 20 to 25 years, and there seems to be some kind of a link, but the nature of this link is both complicated and controversial amongst the people who work in this area. So why? So first of all, there's plenty of studies that look at the relationship between diabetes and various mental health problems, but many of these studies tend to lump together people with type 1 and type 2 diabetes. There are also lots of studies that try to look at symptoms of different mental health problems, depression, anxiety, but they lump together people who have symptoms and people who have full-blown clinical disorders. So it's sort of hard to tell whether people are more at risk of developing an actual clinical problem, or whether people have certain symptoms, but actually they don't have a clinical problem that needs other kinds of medical attention. There are also studies that look at increasing high rates of distress, but that don't necessarily pick out the specificity of diabetes. So one thing that we know in the branch of psychiatry I work in, which is called medical psychiatry, which is dedicated to the psychiatric care of the medically ill, is that many subpopulations with chronic diseases are at increased risk for particularly depression. And so there's a lot of research that looks at people with diabetes and studies their risk or their rates of depression, but without necessarily picking out the specific aspects of the disease. So we don't know if that risk is a general chronic disease risk, or whether it has something to do with the nature of type 1 diabetes itself, and if so, what. So unfortunately, the original question about, is there some specific causal link between the disease itself and these other psychiatric conditions, these other conditions? We, at this stage of the knowledge, we can't answer that question. In practice, just to add as a kind of interesting bit of information, the most common problems that we see in the type 1 diabetic group are problems related to anxiety, and that could include clinically significant anxiety that requires, psychiatric treatment, as disturbed eating behavior, all the way to full eating disorders, although I would say that a variety of non-specific eating problems are more common than full eating disorders. And then we certainly see plenty of people with depressive syndromes. As I've said, depression is extremely common in the population in general, even more common in populations with chronic disease. So it's not clear that that's diabetes specific. There was another question under the same theme, which was quite specific, actually, asking about whether there is data about whether pump use or multiple daily injection use is more likely to give better results in terms of people's mental health. And I would say that, again, this is really not clear, and it's probably in reality, this is individually determined. So it's going to, the degree of comfort or distress a person is going to experience in their routine is affected by a great many variables, not merely the technology itself. So including their personality, their lifestyle, the other demands on their time, et cetera. So I think that this is going to be something that's largely individually determined. I actually came across a really interesting paper when I was thinking about these questions. That seem to indicate that if you give people the choice of what technology they want to use, they do well regardless. So it actually really has nothing to do with the technology itself, but more to do with finding something that works for you. And I think you're going to see that that's a theme that's going to come up again and again as we go over the questions. Another question that came up under this heading was whether after many years of having type 1 diabetes, what are the consequences on the brain? Is there a higher risk of neurological disease? So the best way I can think of approaching that question is to say that there isn't a direct risk of neurologic disease per se, but somebody who has many, many severe hypoglycemic episodes over time, over a long period of time, is at greater risk of developing cognitive difficulties. And it's not a dementia in the sense of an Alzheimer's dementia where it continues to progress even if the person regains control of their disease. So it is possible, but there isn't an association per se with neurologic disease. The other association is perhaps indirect in the sense that someone who develops vascular disease as a complication of their diabetes is at greater risk, for example, of stroke. And so there may be sequela of having a stroke, for example. So that's an indirect relationship between type 1 diabetes and brain disease. And then finally, under this theme, there was a question, what kicks off a hypoglycemic episode? Is it a process that starts in the brain or in the liver? So I'm venturing a bit out of my depth here, but I will do my best to answer this. Obviously, there has to be some kind of imbalance between the level of blood glucose and the quantity of insulin that's circulating in your body. What I can tell you is that in a person without type 1 diabetes, the counter-regulatory hormones that are released protect the body in all circumstances against falling into hypoglycemia. For somebody with type 1 diabetes, the part of that hormonal response that is mediated by the pancreas is not working, whereas the part that's mediated by the central nervous system is working. So, but it's unfortunately not a full response. It only does half the job. So you're not able to compensate obviously the way a person without the disease can. So it's a pancreas problem, but your central nervous system is still working as it should. Okay, does anybody want to add anything under this heading of the link between diabetes and mental health? Okay. The second group of questions concerned the theme of burnout. And there were a few different questions under this heading that were reasonably similar. So I'll try to address them all as a group. So, I mean, I don't need to tell you that this is something that affects a lot of people. It may even, in fact, affect you at different times in your life, may affect everyone at various stages, depending on what they're going through otherwise in their life and the demands of the disease at any given point in time. I think in practice, in my clinical practice in any case, what we try to do is to focus on what is particularly onerous for this person. Right? So there are different things that can be onerous that can all lead to a person feeling burned out in terms of managing the illness, but different aspects of managing may be more onerous to someone than to someone else. And so that's what we really try to focus on, is to get clear on what is it about the disease that is particularly difficult to you at this time in your life in light of everything else that's going on, and to try to develop strategies that are specific to that. So I would say that's probably, on your own, probably the most useful thing that you can do is to try to get clear in your own mind about what it is that you're having difficulty with. And I think then it might be more straightforward to be able to seek out assistance for that specific thing. Because as you know, the burnout phenomenon includes a lot of different things. So it's difficult to give tips that focus on all of those things. And it's going to depend a great deal on individual needs. Anything else about burnout that's worth mentioning? And like when we did this in person last year, one of the really nice things was that people actually shared their own tips with each other. So people should also feel free to write in if they have something that they want to add to what I'm saying from their own experiences. The next group of questions concerned anxiety. And I will admit there were a couple here. They weren't formulated as questions and they were a bit in shorthand, so I wasn't entirely sure what the question meant. So if you're out there and it was your question, please, by all means, clarify it or set me straight if I'm going down the wrong path. So there was a question or a statement that said, handle the fear of death and type 1 diabetes. So I wasn't 100% sure I understood that one, but I assume it means the possibility of having a severe hypoglycemic episode and dying. There was a question about getting over the fear of traveling abroad and the uncertainties that come with travel. And then there was a final statement about fear that one's body is different. That one I wasn't sure what the person was looking at. So again, if you're out there, feel free to clarify. So I will say in general, oh, sorry, I'm hearing an echo. Are other people hearing that too? Is that bothering you, Pam? Is there anything we can do about that?
I think it's just because people are coming in.
Okay.
And it's just kind of the lag there because it's kind of coming in and out. So
it seems like it's improved on my end too. So
yeah, mine is good now.
Okay, good. So anybody who's hearing strange echoes or anything that's bothering you, just give us a sign, because then we can always give people a second to join in. So I want to say a few general things about the treatment of anxiety, because all of these questions concern anxiety about different things. So there are different ways that you can go about treating an anxiety problem, and it depends partly on the severity of it. It also depends on what is the thing that you're afraid of. The mainstay of the treatment of anxiety involves, in some way or another, because there are different kinds of therapy, but are in some way or another exposing oneself at some point to the feared thing. And that might be a real exposure. That might be an exposure that you do in your imagination together with your therapist. That might be a virtual exposure. And then there will be some discussion about how that exposure went. And what were the problems that came up, what were the feelings that were aroused, etc. So that is really the main kind of approach. So the person who asked, how do you get over the fear of traveling abroad? The approach would be what we called gradual exposure, where you would, in small steps, build up towards the ultimate feared stimulus, which is the trip abroad. But you wouldn't start by saying, off you go and purchase a ticket to Spain and get on the plane, and I'll help you get on the airplane. It would start by doing small things like doing very local types of trips, by perhaps doing day trips and then staying overnight and then going abroad. It really would depend on what the feared thing is. Is it actually going to another country? Is it more like taking a plane, but once you get there, you're fine? Is it, being in the airport in this day and age and fear of contracting COVID? So it could, depending on the person, it could be something that's quite specific, and then you would work on exposing the person towards that. There are also various types of medications that we use in the treatment of anxiety, and these are particularly helpful when a person is so anxious that they're not actually able even to work in therapy, because the thought of doing the work or the steps they have to undertake are simply too anxiety. And so I don't need to get into the details now unless somebody's particularly interested, but there are different classes of medication that we could use to do that. There are even some medications that are very really meant for very occasional use that would be appropriate. And I've certainly seen this in practice, people that are really just afraid of taking the plane. And there's really no other feared situation. And the only thing they need help with is being able to endure the plane ride. In some cases, actually taking the medication that they're going to do once a year, because they don't take the plane that often, is actually the way to go for those folks. So those are the two broad approaches. I think the question about the fear of death, if it really was a fear of death from a hypoglycemic episode and diabetes, is really interesting, because I think it challenges your thinking about, well, how am I going to expose somebody to that circumstance? And actually, it turns out I'm working with somebody right now who is extremely afraid of having hypoglycemic episodes. And what we have been doing is not intentionally exposing her to hypoglycemic episodes, provoking them, but rather having her, as much as possible, live her life and not constantly allow herself to be hyperglycemic. But the exposure is actually to being normal glycemic, because the more that you're normal glycemic, the more you run the risk of having a hypoglycemic episode, and then learning to develop the confidence that she can manage that episode if it arises. So I hope that addresses that question. It's the same approach, but you have to be a little creative and diabetes specific about how to go about creating an exposure. I think I see something in the chat. Pam, is there something I should respond to there?
I'm just responding back, but the question was, how would you get exposure to fear of dying early, since they do say that T1D has a lower life expectancy. So, and another question just came in as well. What is the T1D life expectancy or average for many T1s? There is just a concern that someone wasn't worried about this until now, but.
Okay. I'm going to pass on the second question, only because I think it's really going to vary based on the person's state of health. So I think a person who has the disease but who's otherwise well, who's been fortunate enough not to develop complications, probably has a different life expectancy than somebody who has complications of disease or has some other medical condition. So I think that's going to vary depending on the person's state of health. So I think the way I would think about the fear of premature death or shortened lifespan is that it's a species of fear of dying more generally, which is not actually specific to type 1 diabetes. There are lots of people out there in the world who fear dying, and necessarily what they're saying is they fear dying prematurely, because we're all going to die. But I think there are some people who are fearful that they're going to, whatever they do in life, or of the things that they do in life, these things are going to put them at risk of premature death. If they travel, if they, drive on a busy highway, if they take medication for something, that whatever they might do in their life, somehow they're going to be at risk for dying. And so it's a good question. Obviously we wouldn't intentionally expose somebody to something that's going to really put them at risk of dying, but rather, again, break it down, figure out what are the different things that they're afraid of in their fear of dying, expose them to those things, but also work on the thoughts and emotions that are behind the fear of dying to try to identify what is it, what are they thinking, what are they feeling about dying that's increasing the anxiety so much. And often you can identify specific thoughts like, I'm going to suffer terrible pain, or I will be unable to do anything myself and be completely dependent on others for a long period of time before I die. And it'll be terrible suffering. So usually you can identify some thoughts and you can work with people on developing more balanced thoughts about their future prospects. Hopefully that addressed that part or that nuance on the question. So the next heading was depression, and the question was actually quite specific. It was from a person who said that she experiences depression, and she's been seeing a psychiatrist, and she's taking 2 medications, but they're not really helping her. And she's wondering what other options and treatments are out there for the treatment of, well, she says depressed diabetics, and I will say that the treatment of depression in people with diabetes is not different than the treatment of depression in anyone else, except that some medications you want to just be attuned to the possibility that they can increase hyperglycemia. So that's really the only caveat. I mean, obviously, I don't know this person's individual circumstances, but I can simply say that there are many, many medications available on the market that are available for the treatment of depression. And this person seems like they've gotten to a situation where the medications they're taking are not working for them. And it's very appropriate in the circumstances to say that and to sort of say, I'd like to explore other options, or to simply say that she's not feeling well and see what other kinds of options are out there. There are also a variety of different types of psychotherapy that can be done on their own or in combination with taking medication. And obviously, when somebody has tried a lot of different treatments and nothing seems to be working and they're still not doing well, there are treatments that we reserve for people who are in those circumstances, including electroconvulsive therapy, transcranial magnetic stimulation. So these are treatments that are more difficult to find. They're often based in cities and bigger hospitals, and they're really reserved for people that have tried a lot of different things and can't seem to be feeling better. Is there anything that anybody would like to know about depression? Well, that's often a topic that people have some concerns about. If not, I will go to the next. It's only one question, but it was quite an interesting question under the heading of guilt. And so the question was, how do you live with guilt after not having controlled your blood sugar perfectly, when ultimately you end up developing complications, and these really diminish your quality of life at a point in your life when you actually should be really healthy and able to do lots of things? So, I had to think hard. This is an interesting question, and it made me think a little bit, because in this case, the person is feeling guilty about something that's already happened, that they believe that they have brought on themselves. So it's guilt about their own behavior towards themselves. So one of the things I thought about when I reflected on this question is that the person's assumption here is that, in fact, everything that happens in the course of their disease is in their hands. And in fact, it isn't. Yes, of course, you bear the responsibility of the management of your disease. A great deal of the treatment and taking the treatment and making sure that it's going well is dependent on you. But of course, we do see people who work really hard at their disease and still develop complications. We also see people who don't seem to do a lot for their disease and don't develop complications. So one of the things the message we can conclude from these kinds of clinical situations is that you can't actually, everything isn't in your hands. You're not controlling every variable. And so it may be the case that the things that were in your hands, you didn't manage as well as you could, but there are also lots of other things that aren't in your hands. One of the things that I learned from the people that I see is that even though diabetes is a disease, it's not exactly the same disease in every single person. There are people that have very different experience of illness in terms of their ability to get control of their sugars, their responsiveness to insulin, et cetera. So there are a lot of variables, I think, that are not always in your hands. So I think that's one thing. And that's a bit contrary to, I think, the message that a lot of people receive in terms of the amount of responsibility that everything's resting on them. But I think that it seems to be the case if we look at large clinical populations that, in fact, individual excellent control is not the only factor that eventually determines outcome. The other thing that I because people do often, and not just in the case of feeling guilty about complications, but feeling badly about past behavior with respect to their disease, whether or not they develop complications. And one of the things that we say a lot in medical psychiatry is that people make the best adaptation to illness that they can. And this doesn't mean that everyone's adaptation is good, but people use the coping strategies that they have that are at their disposition at that stage in their life, at their level of development and maturity, to do what they can to manage the disease. And that I think what I would say to this person if I was working with them is that, at that stage in your life, that was what you were able to do. At this stage in your life, maybe you're able to do something different, and we'll work on you being able to use those strategies now. But people will give what they can, and if they can't give more than that, maybe because points
we
that
just had somebody join, so kind of went choppy there. I have a couple questions coming through in the chat, if I can fire them at you.
By all means.
So going back to the topic of depression, is there a comparison study comparing T1D and non-T1D people with depression?
So the question is it about rates of depression in people with diabetes, type 1 diabetes versus no diabetes?
Yes.
Right. So yes, there's a literature on that. And it seems that people with type 1 diabetes and type 2 diabetes as well have higher rates of depression than the general population, so the non-medically ill population. The thing that's complicated about this, and we were speaking about this earlier in the session, is that you find higher rates of depression in all chronic disease populations. And so it's not clear whether that risk for depression is something specific about type 1 diabetes, although of course individuals may find specific things in their own experience to be contributing towards their depression. But at a group level, it's not clear whether that's something specific about diabetes or whether that's the effect of having a chronic disease. Because we find pretty similar rates in type 1 diabetes, say, compared to Crohn's disease, compared to cardiac disease. So that's not been sorted out. Okay, and there's another question. Is there a link between roller coaster blood glucose levels and mood swings / hormones? Okay, so this is not a literature that I know, so I don't want to give you wrong information. What I can tell you is that I have had many, many female patients who have remarked on this association. And for some, it's quite a strong association, and they even know when their period's about to come because they see their glycemic control becomes more difficult. To others who say, yeah, sometimes there's an impact, but it's not that big. But it's certainly something that patients have commented on. And those who are quite affected, have to make quite a few adjustments in their dosing at the time of their period as a result, for example.
Okay, and can I keep asking questions?
By all means. That's
Okay.
the best part.
How should a parent deal with the guilt that their child has type 1? As a parent, this person feels like it's their fault and that they gave it to their child because they are type 1, and it's a depressing thought to have.
The parent also has type 1?
Yes.
Is that correct? Okay. Now, so again, some of you out there may be much more knowledgeable about this than I am, but my understanding is that the hereditability of type 1 diabetes is actually reasonably low. And that even, I think there are like some unusual genetic syndromes where you see it going from parent to child and so on through generations. But I think even in the case of a parent-child, that is not necessarily any kind of genetic association. So I think before you spend a lot of time feeling guilty, I would encourage this person to actually seek out that information and be really sure that there is some kind of genetic link, and which may not even be the case. But obviously, even if it is the case that there was a genetic link, we pass on all kinds of things to our offspring, and we do all kinds of things with our offspring when we parent them, and we do our best to give our kids the best possible opportunities and upbringing and so on, but you certainly cannot control what is passed on to you and what you pass on in genes, except for some very, very rare clinical situations where 100% of the people get the disease and they know they have the gene and they know they'll pass it on to any children. I think apart from that, we simply don't have that kind of certainty with the vast majority of diseases.
Okay, then the next question is coming from a parent that does not have type 1. What can they do for their child who is 8 years old to prevent him from carrying the burden mentally? They are starting to involve him and want to use the right approach.
So I don't see children, I only see adults. So I don't have firsthand experience of what it's like for kids. What I do see a lot of are people, adults who have had diabetes since they were children and who reflect on their experiences as children and how it was with their parents. And I don't know that I have, all of the people that I've ever met, I don't know that I've ever met anyone who said, my parents did too much for me. They cared too much, they were too present, they were too involved. Occasionally people will, it's a joking manner, say, oh, my parents were quite overprotective of me. But even that, it's fairly uncommon. I mean, I think kids only know the life they lead. And so they will adapt to the circumstances that they're in. And I think that I've seen adult patients talk about different approaches. Some parents who really help their kids become independent very young, others who are quite involved really up until young adulthood and beyond. I think that the thing that you do is probably less important because it's going to depend on your child and his or her personality than the fact that you're trying to do something. And so the fact of being involved and trying to find a strategy that works for your child and trying to help and support is, I think, ultimately more important than the specifics of the thing that you finally decide to do in terms of involving them or giving them autonomy. Lots of things seem to work, actually, and I think it's because they work because I think children feel the investment of their parents in them and doing well with the disease. At least they remember it that way. So reassure yourselves that whatever you do, when they're adults, they will remember that you did right by them.
Next question I'll ask, I don't know if you'll have the answer to this one. Is there any way to clarify if you have brain damage or loss from having T1D for many years?
Yeah, so we spoke about this earlier. I don't think there's a direct link between type 1 diabetes as such and brain damage. I think the link is, and I don't know that I would even call it brain damage per se, but that there can be cognitive difficulties after many, many years of many episodes of severe hypoglycemia. The other link that we spoke about that's indirect is through the development of vascular disease that can contribute to the development of stroke. So that's another way in which you can be at risk for brain disease or brain damage, but the link is not direct.
Okay, and there's a little bit of chat going on that maybe you could add some information to, and it's just wondering if anyone knew the hereditary percentage of T1D passing it on to their child, and there's chat that it's about 3 to 5%, or do you know any resources of where they could get that information?
The resources that I know, I'm not sure where the person is living, but the best resource I know are genetic counselors who really are up to date on that information. And I assume these days, with all of the developments that have happened so quickly in teleconsultation, that might actually be something that's viable to arrange, even if you're not living in a center where there's genetic counseling in town.
Okay, and I have another question that came in. This person is type 1 and has a daughter, and was always given choices. How much do you want to take on alone, and what would you like to eat to treat a low? And they're just saying that sometimes they feel like very little choice in life, and this helped as a child, so empowering. So that was just a comment, not a question. Yeah.
Yeah, I think that's a great comment, and as I've said earlier on many different topics, so much of this is individual, right? And there will be the people who will thrive having everything dictated to them, but I don't think you're going to go wrong trying to give choice or trying to prescribe things, because your child will let you know whether they tell you directly or indirectly through their behavior, whether the approach is working for them or not. I think what matters and what they're going to remember and what's going to help them, I think, manage their disease themselves eventually is knowing that they were supported and that they could try different things, and that they could respond, and that their responses would be heard. I think that's really all that matters. And I don't think people need to worry so much about getting the right approach, because I think that's something you'll figure out.
Thanks for answering all those questions in the chat. There's nothing as of right now left to ask.
Yeah. Great. So the next group, or the next question actually, concerns eating disorders and body image. And so again, this wasn't a question, so if the person is out there and wants to say more specifically what it was they wanted to discuss, feel free to do so. And in the meantime, I'll just give some general information. So it's a statement that the person has fear regarding their body, type 1 diabetes, worries about food, worries about diabulimia, worries about dianorexia. So what I will say is that there are higher rates of disturbed eating behavior in people that have type 1 diabetes compared to people that do not. That the rates of formal eating disorders, like you see on TV reports and so on, like anorexia nervosa and bulimia nervosa, don't seem to be elevated, but that there's a variety of disordered eating behavior that is much more frequent. And this can be, whether or not it meets a formal psychiatric definition of a condition, these disturbed eating behaviors can be quite serious or not, depending on the individual. But so unlike what I said earlier, where sometimes people have symptoms but not a full clinical syndrome, in the case of disturbed eating behavior, having that problem might actually be quite serious, even if you don't meet the full definition for a psychiatric problem. So that's something that we do see. All kinds of variations on that, from binging to binging and not bolusing, to skipping insulin altogether, not binging, but just not taking insulin. So we see all kinds of, to the other extreme, which is trying not to take insulin and not eat. So seeing all kinds of versions of disturbed eating behavior in the context of type 1 diabetes. what I can tell you as well is that there are good programs for the treatment of eating disorders that are out there, where people with, even if they don't have a formal diagnosis, could actually get assistance. The only caveat is that many of these programs were not developed specifically for people with type 1 diabetes. And so they have to be adapted, I think, to meet the needs of people with type 1 diabetes. So one of the things that I work on in practice with people with eating disorders that I'm seeing in addition to the treatment of the specific disorder is how to develop or redevelop a more natural or healthy relationship with food, which, quite aside from an eating disorder or disordered eating behavior, I think becomes, disorder is maybe not the right word, but is interfered with by the disease, right? So whereas a person without diabetes, feels hungry and then they go and eat something, a person with diabetes, I think, has a more, what we've been calling in practice, a more mathematical relationship with food. And so everything that you eat and all of your physical sensations are mediated by this calculating that you're always having to do. And so an important part, I think, of adapting standard treatment for eating disorders protocols to people with diabetes is taking into account the way the relationship to food has already been altered by having to manage the disease. So pandemic, we'll skip for now. Somebody asked a question about what they call false hope or acceptance. And so the person says, we often hear that a cure is just around the corner, and this is a pain point for the community. It's easy to become cynical. When does this kind of hope become counterproductive, and is it healthier to resign oneself to a future of acceptance of a chronic situation? And related, how harmful is false hope in the mental welfare of those living with a chronic and dangerous disease? So I want to tell you that this is not the idea that the cure is around the corner, although being specific and painful in the type 1 community is actually, unfortunately, common throughout medicine and medical research. And it has been 50 or 80 years that researchers in psychiatry have been saying the same thing about depression, about schizophrenia, about bipolar disorder, and sending those same messages. And it's probably a bouts of unwarranted optimism, perhaps, or exuberance about the work they're doing, the desire to instill hope in people. But I agree with you that it can be disappointing if you take those messages at face value and in isolation and think, oh, this person really means there's something coming. That said, the treatment of diabetes has changed enormously, even in the time that I've been in practice. And as opposed to there being one big cure that has radically changed everything, there have been many incremental developments, I think, some of which have greatly helped people and improved their quality of life. And so I think the thing that strikes me about this question is that I don't think it's a choice between having hope and accepting the disease. I think there's room for both. I think there's room to have hope, to explore new technologies, to try new things, and to see what's going to improve your own quality of life and your own management of disease, but at the same time also accept and work towards living well with the disease now with the tools that are available to you. So I think there's room for both in a balanced way. So somebody asked, now we're talking about questions that are related to family and significant others. What are some early indicators to watch for that may signal our type 1 diabetic is struggling with mental well-being challenges, particularly young adults? So I can give you some general kinds of things to look for that many of you probably know already from knowing a bit about depression and anxiety and other common mental health problems. But the main thing is really a change in this person. you know your child, you know your loved one that you live with, you know what gives them pleasure, you know how they organize their time. When you start to notice that these things are changing, doesn't necessarily mean they're developing a mental health problem, but it's always good to ask the question, hey, what's going on with this person? When you see that someone no longer is interested in things, that they no longer take pleasure in things that were once of interest to them, that they are isolating themselves from others. You know, not everyone is extremely sociable, but to isolate yourself completely from your family, that's unusual. That there's changes in their bodily function. They're not eating well, or they're eating too much, they're sleeping too much, or they're not sleeping enough, they're getting up, wandering around in the night. That they're not paying attention to their basic self-care anymore, or that they're even doing things that maybe seem harmful to them. These are times when I think you want to be concerned, and you want to check in with them and find out what's going on if you can. So I think I will now see if it's a good time to turn to pandemic-related questions. I don't think there was anything specific that was asked, but it was simply stated that there's a lot of concerns about having the disease and going through this particular time.
We do have some that came through on the chat as well.
Okay.
If I can ask you that one.
Absolutely.
Do you have any recommendations on how to deal with getting diagnosed with T1D and shortly after celiac? This person was diagnosed a year ago and is still getting a grasp on T1D and now celiac as well. It's a struggle and eating can often be a chore. Any suggestions for the burnout?
Oh, only that you're absolutely right that it's just miserable. And I have unfortunately met a few people who are in similar circumstances to you. And yes, it seems awful to be in that situation. You know, it makes me think actually maybe something that might be helpful to you would be to see if you can be in touch with any of them, because they might, through this forum or through other resources, because I think they're probably the best people to help you kind of navigate your way through that. Because I gather there is a great deal of both experimentation, but also not feeling very well, and unfortunately, and a lot of frustration. So anything that you can do to get information from other people to reduce you having to reinvent the wheel, I think that would be probably the best way to reduce your own kind of burnout and exhaustion with it. Oh, and I think people are already replying, and hopefully those people will have some helpful advice to share.
Yeah, there is a few in the chat, and they're all sounds like they're happy to share some recipes and help along the way as well.
Great. So I'm not sure if anybody has any specific points they wanted to make about the pandemic and what you're going through during this time. You know, what I've been hearing from my patients is their main concerns have been around work, have been around whether they should go to work, what kinds of precautions they should expect at work, whether they shouldn't go to work. I do know that many people have been able to not have to go to work in person, and they've had some medical documentation to support that, and that's been very beneficial to them because they were quite anxious about it. I know some other people who have asked that there be accommodations at work, so they go to work, but they've asked for some accommodations, and those have been, generally speaking, respected. My understanding is that you're not at greater risk of catching coronavirus, and that the main worry is if you're having trouble controlling your blood sugar and you become infected, that the course of the infection then might become more complicated. So I think decisions about work have to be made with consideration of your general state of health. and the specifics of the management of your disease and how that's going.
And there's a question wondering if there's any hard data on details of COVID and people with T1D getting it, and it's like symptoms or experiencing worse symptoms or.
Yeah, my understanding is that it if anything, it's not the COVID that's going to be worse, it's the diabetes that's going to be worse. That once you have a viral infection, the management of your blood sugar is going to become more difficult, as it does with any viral infection and indeed with bacterial infections. So that, I think, is the extent of it for the moment. I haven't seen anything that specifically looks at a group of people with type 1 diabetes and coronavirus infection.
Yeah, and there's another comment that just came through that as a parent with a child with T1D, they're worried about getting it and getting really sick and being too unwell to look after their child.
Yeah, I think it's a very legitimate concern. And, you know, I think it's one that everybody who's got dependents is concerned about. And so, you know, the best thing you can do, I think, is follow, maybe not so much I know that a lot of people are sort of confused by some of the messages. Do we get together for Thanksgiving, but do we not to get together for Thanksgiving? All those kinds of things. But actually, I think the basic messages, which is wash your hands, keep your distance from people, wear your mask. I really think that if you can stick to those three basic things, you're actually going to be in pretty good shape, because that's going to do most of the work for you.
There's another question that came through wondering if there's an A1C that makes it less likely to have issues with recovering from COVID.
I cannot answer that. I'm sorry. I don't know. I do believe that being as close to normal glycemic as possible makes the course of your illness as similar as it would be for anyone else. But that said, within the population, the range of severity of the course of disease varies greatly, mainly with age, but not only.
Okay. I don't know if you'll be able to answer this one either. The question is, could a T1D who gets COVID be asymptomatic, or would they automatically experience hypoglycemia?
No, I don't think there would be anything automatic about it. And it's also the case that in the early days of the infection, the viral load is not great enough to necessarily have any kind of destabilizing physiologic effect. So I don't, in the same way, probably when people get colds, sort of the day before the cold, maybe things are going fine with diabetes, but then once things really get going, that's when you start to notice, once the viral load increases, that's when you start to notice more of the instability, or with a UTI, for example. So that would be I think it's absolutely possible.
Okay.
I think there's a question about age.
Yes, I don't quite understand, Andy, what you're asking here, mainly with age 60 plus, 70 plus, 40 plus.
Is it the risk of severe disease? I think the risk of severe disease, I believe, increases quite dramatically after the age of 70.
Okay, there's no more questions in the chat here. We're almost coming to the end. Oh, there's Andy was asking, it was mentioned risk for COVID dramatically affecting a T1D. Is that at a certain age?
Risk for COVID. No, it's the COVID itself. So it was mentioned the risk for, I'm not sure that I understand the question. Having COVID can lead to more difficulty to manage the disease in the same way that all viral infections can lead to glycemic instability and difficulty to manage the disease, yeah, which can complicate the disease course in turn.
Okay, well, we're at our full hour. Was there anything else you wanted to touch on before we wrap it up, Dr. Mona Gupta?
I think I have covered all of the questions that were sent in. If there's anything that anybody wants to add here, or anything that you want me to clarify anything, I'm happy to do that.
Okay, there's nothing coming through on the chat right now, so just lots of big thank yous. And I would like to thank everyone for joining. And a special big thank you to you, Dr. Mona Gupta, for taking the time to spend this last hour with us. That was fantastic. I'd just like to remind everybody, don't forget to check out our website, jdrf.ca, for the latest updates on the next education series, Tech Talks, which will be November 16th and 17th, and our Connection series on October 28th. So thank you all so much.
It was really a pleasure to be here, and I'm very happy that my 3 very noisy adolescents did not interfere with our session through their screaming and fighting and carrying on. So I wish you all a pleasant evening.
Have a nice one.
Bye.